Yes, please start.
So good morning, respected judges and my dear colleagues. I'll be presenting on the viability of full-thickness skin grafts with cicatricial ectropion of the upper and lower eyelid in acid burns. I am Dr. Anisha Moitra and I am from the Regional Institute of Ophthalmology, Kolkata. So in this study, we explored the effectiveness of full-thickness free skin grafts for correcting cicatricial ectropions in eyelids damaged by burns. Cicatricial ectropion can lead to severe complications which, if they are not addressed, can lead to severe complications, and hence it requires identification of effective treatments. Now, results from malposition or deformation of eyelids following severe facial burns leads to eyelid malfunction and exposure keratopathy. This not only threatens vision by causing corneal damage, but also significantly impacts the cosmetic appearance of the eyelid. Our primary aim was to assess the viability of full-thickness free skin grafts in the correction of upper eyelid cicatricial ectropion resulting from acid burns. This was a retrospective study of 10 patients treated over 2 years for eyelid cicatricial ectropion using full-thickness skin grafts and tarsorrhaphy, followed by tarsorrhaphy. The inclusion criteria included patients with acid-burned faces showing upper or lower lid cicatricial ectropion, and those with some visual capability, that is vision is greater than 660 and good Bell's phenomena. And exclusion criteria were cases with severe cicatrization, preventing lid closure or entire corneal exposure keratitis. Now all patients received 3 doses of injection triamcinolone and 5-fluorouracil pre-surgery to prepare the tissue, and surgery involved creating an elliptical defect, removal of scar tissue and placement of a full thickness graft from the retroauricular area. This is the video of a patient, one of our patients with severe bilateral upper eyelid cicatricial ectropion. Now, so this patient, we first excised the scar tissue, and then we harvested a skin graft from the retroauricular area and then resutured it to the recipient bed. For this patient, a repeat surgery was required, for which we again harvested skin from the inner aspect of the arm, and the fat from the skin was excised and was again resutured at a later date onto the same area. So this is the procedure, and this is how we have sutured it onto the recipient bed. And this we have placed a tamponade after the surgery so that the graft fixates well on the recipient bed. And then we have done a tarsorrhaphy to splint the eyelid. So these are the list of patients that we had performed this procedure on. As we can see that there has been a significant improvement in the MRD, especially in patients with upper eyelid ectropions. There was 100% graft viability was achieved in all cases, indicating a high success rate of this technique. And minimal complications were noted, such as mild contraction in 4 patients and graft hypertrophy requiring revision surgery in 2 patients. There was significant improvement in the cosmetic outcome, improving both lid functionality and appearance. Success was attributed to rich periocular blood supply and meticulous surgical technique. Graft hypertrophy and contracture were challenges but could be managed with additional repeat surgeries like I just showed. And substantial improvement in eyelid function and cosmetic appearance was achieved, enhancing the patient's quality of life. Full thickness free skin grafts have proven to be a viable and effective option for treating upper eyelid cicatricial ectropion resulting from burns. Despite the potential need for revision surgery due to graft hypertrophy, the technique offers significant functional and cosmetic benefits. Further research is encouraged to enhance grafting techniques and reduce complication rates, and we obviously need to include more patients in the surgery in order to reach a statistical result. We extend deepest gratitude to patients and medical team for the participation in education. Thank you. These are some of my references.
Thank you, Anisha. I have 2 questions. One is, in this type of cases, usually the post-auricular area is also involved. Means you cannot take the graft from that area.
So
And in that case, what is your plan?
So ma'am, in cases where the post-auricular area was involved, we have usually taken grafts from the upper aspect of upper inner arm, and also from the abdominal area, lower lateral abdominal area.
And what are your complications you came across? Because the post-op period is not that smooth usually.
We observed.
But you have not shown any of the complications. You said 100%.
Ma'am, the graft uptake was 100%, but obviously during the course of 6 months, there has been cases of graft hypertrophy, which has gradually resolved over time. But the major complication, or rather I would say the repeat procedure that was required in some of the patients was a repeat graft surgery was required because of the nature of the injury, there was repeated contracture.
That you should include also, no? What are the complications?
Why don't you use the supraclavicular area? That's more easier to use. Why going to the abdomen and going there? You've never tried supraclavicular?
We have explored it, yes, but then...
And the other thing, you are putting so much stress on the skin graft. I think the key role in your study and any other study is on the 5-FU injection. If you do this study in patients without giving 5-FU injection, the failure rate will be drastically increased because band effect and the retraction effect increases too much. So 5-FU you haven't stressed much, but the major role is by 5-FU and TCA injection that you are giving. The band and the fibrotic area, it gets very softened. And that is what helps in the success, increasing the success rate of the graft. So that is very important. What interval are you keeping between 2 injections?
3 weeks.
3 weeks. So minimum 2 weeks and then go to 4 weeks also. Okay, thank you.